Hello, everyone, and welcome to another Ask the Expert. Just after our previous one and a week before the next one, they're coming at you thick and fast at the moment. I did the wrong way round on that. That was a bit weird. Today, the Ask the Expert is about the National Liver Offering Scheme's patient survey, and if that sounds a bit complex to you, that will be explained in a minute. We are currently joined by Laura Stamp. She is the lead nurse recipient coordinator for the NHS Blood and Transplant organisation. I guess it's an organisation, that's probably the way. We will also be joined by Professor Doug Thorburn. He is running a little bit late with doctory things that he does. He is a consultant hepatologist at the Royal Free London Hospital, and he is a professor of hepatology at the University College London. He was also the chair of the Liver Advisory Group, just to give his credentials a bit of a boosting, which was a committee that advises the NHS Blood and Transplant on liver transplant policy. So he's a big brain man who will be joining us when he can. In the background, we've got Martine, our head of research here at PSC Support. She's going to be checking out your questions that you submit. You can also, she'll be dropping some links into the chat. Questions are a good thing. There's a little Q&A button at the bottom of your screen. If you click on it, you'll be able to submit questions. And then once Laura and Doug have done their segments, we'll have a Q&A session. So we will get around to answering them. If they can be kept on topic, that would be really, really useful. So thank you for that. And finally, I am the PSC Support Operations Manager. You've probably seen me a few times, and I've got a very flowery top on today. I didn't quite realize how nice it would look, so I'm quite proud of that. So thank you for joining us. I'll do a proper introduction now. Thank you for joining us. Doug and Laura are here to talk to us about what the National Liver Offering Scheme is. And now that it's been in place for 5 years, it's been having a bit of a review. And so they have created a survey to garner opinions from patients and their networks. And we've created a website page that you can go to. It gives a bit of background, which will also be covered here in this talk. And then that links through to the survey for you. Links will be dropped in the chat periodically through as we go. But other than that, I'm going to hand over to Laura. Doug will join us probably in a couple of minutes, halfway through Laura's talk. So I apologise if you get interrupted, Laura.
No, that's quite all right. Thank you very much, Matt, for the introduction and covering off the purpose of the webinar. Firstly, just want to say thank you very much to everybody who's joining today for your time and participation, because your views and opinions are highly valued and integral to the review of the National Liver Offering Scheme. So we'd really like to hear your views and opinions after hearing this webinar by submitting them through this link to the survey. It is hosted on your website and the British Liver Trust website. And really the purpose of this webinar is for us just to run through a bit of a presentation as to the background of what the National Liver Offering Scheme is, why we're doing a review, and how the review may and the recommendations may end up looking in the future. So Doug is, as Mark said, the chair of the review committee, very much the expert in this, and I've just been supporting the committee sort of from the nursing point of view. My background is a liver transplant coordinator at King's College Hospital from 2011 to 2017, and I've been in this role now since then, 2017, representing the transplant coordinators of the country across the different specialties. So it's the first time I've been involved in a review of an organ allocation scheme. So I'll just really start you from the very beginning, not knowing who's on the call and what point of a journey people may be at with transplantation. So I'll just start very, very much at the beginning, and apologies if I'm teaching anybody something they already know. So to go on the liver transplant waiting list, a person must have a liver disease that will be helped by liver transplantation. They'll undergo a set of tests and checks called a transplant assessment, and that's to make sure that a transplant is the best treatment for them and their liver disease is severe enough to actually require transplantation at that time. It's to ascertain that they'll be able to recover from the transplant. It's to ascertain that they'll be able to look after themselves and have relevant support post-transplant, for example, taking their medications for anti-rejection and going to checkups. But most importantly, the transplant assessment is to determine that that person is more likely to be alive in 5 years' time with a transplant than without a transplant. So while the person's waiting for transplant, they will have regular checkups while they're on the waiting list, and this will help the transplant team to check how they're doing and to keep them as well as possible. Now, donated livers mainly come from people who have died in hospital, and there are two types of deceased donor liver depending on how the person died. So we have donation after brain death, or DBD donation, and this means the person had a brain injury which caused their death. This could be a trauma, for example, a car accident, or more commonly as we see today, it could be a result of stroke or a catastrophic bleed in the brain. That person would undergo a series of neurological death tests to have their death confirmed and proceed to organ donation if that is their wish or the wish their family had expressed upon their certification of death. The second type of donor, of deceased donor, is a donor after circulatory death, or DCD donor. And this means the person died after their heart stopped beating. Treatment of the potential donor would no longer be helping them. The treatment they'd been undergoing would no longer be helping them. It would be futile to continue treating them, and they would not survive their period of illness. Therefore, treatment on that person would be withdrawn and stopped, regardless of whether organ donation were to happen. If that person wished to be an organ donor in life, treatment would be withdrawn, and if they died in a short enough time frame, their organs would be eligible for donation. So currently in the UK, half the donors are DBD donors and the other half are DCD donors. This has never quite happened before. We've often had more DBD donors, but they've really equalised over the last few years. There are a couple of differences between livers from DBD and DCD donors in terms of transplantation, but overall patient outcomes are fairly similar statistically. It's important to understand the differences between the two types of donors, as there is a fundamental difference in the way DBD and DCD livers are offered to those awaiting liver transplantation. So livers from DCD donors are offered to one of the 7 UK liver transplant centres for the clinical team there to decide who on their waiting list is best suited to that liver. Blood group must of course be matched. However, what we're focusing on are the livers from DBD donors. So half of the liver donors out there, the DBD donors, and these are offered nationally across the UK via the National Liver Offering Scheme, or NLOS for short. And this offering scheme has been in place since 2018. It did take in excess of about 8 years to actually get to the point of launching. So it was an awful lot of work prior to 2018 to get the National Liver Offering Scheme right for its launch. So the National Liver Offering Scheme is essentially a national list, if you like, and it uses a calculation called the Transplant Benefit Score to determine who is the best match for a particular liver, and therefore be the first person to be offered that liver in the country. The Transplant Benefit Score is made up of a combination of characteristics from the liver donor, such as their age, blood group, and any medical conditions they may have had, as well as characteristics from people on the waiting list, such as their most recent blood test results. So because the Transplant Benefit Score looks at both the donor and the potential recipient, the score is different each time between the different donor and recipient pairs. The liver is offered to the person from the whole UK waiting list with the highest Transplant Benefit Score for that liver. If the doctors think that the liver is suitable, the person being offered the liver gets a call asking them to come into hospital, and the liver is checked for quality assurance purposes by the surgical team before proceeding with transplant. It is important to note that under the National Liver Offering Scheme, livers are only offered to adults, and this is adults with a long-term chronic liver disease or form of cirrhosis, people with a type of liver cancer called hepatocellular carcinoma, and other liver problems that still require a liver transplant but aren't because of cirrhosis, and these are known as variant syndromes. Children under the age of 18 and those in sudden onset or acute liver failure and those awaiting multi-organ transplant are offered livers via different routes, and they are not part of the National Liver Offering Scheme, so therefore are not part of the review. So why is the scheme being reviewed and how does the review work? So it is quite normal for after an allocation scheme has been in place for some time for a review to take place to ensure that organ allocation schemes are fit for purpose and to decide if any changes are needed. So since it was introduced, the National Liver Offering Scheme has been formally monitored by a group of liver clinicians, and there has been feedback from patients and healthcare workers over time as to how fair they find the scheme to be and whether there are any disadvantages to it or any pockets of patients that appear to be more disadvantaged or advantaged than others. As well as positive comments, and there have been some, there have also been some concerns raised about the National Liver Offering Scheme in its current form and particularly how it affects specific groups of patients. So the aim of the review is to decide whether to continue the scheme as it is or make some recommendations for change. We would therefore like to focus your minds as patient and public stakeholders as part of this review to complete our survey as to what you feel the underlying principles of an organ offering scheme should be, and whether the principles that we agreed in 2018 for our National Liver Offering Scheme are still the principles we need in 2025 and beyond. So the three principles in which you could base an organ allocation scheme on are need, utility, and benefit, and I will come on to explain those in a moment. So different people will have different ideas about what fair looks like and which of those principles is more important to them, especially when having a liver transplant makes such a big difference for patients, and some people will wait a very long time. The need of the patient is one way in which you could base your allocation system, and this would mean the sickest people get a liver transplant first because they don't have the time to wait for a liver. So the need goal aims to keep the number of people who die while waiting for a liver as low as possible. However, the sickest patients may not live as long after transplant as other patients who were more well at the time of transplant. The second principle in which you could base your National Liver Offering Scheme on would be utility. So this means usefulness of a liver. So this would mean you would transplant the people expected to live the longest first, and they will get the transplant first. So this would inevitably pick people who are less sick while they're waiting for transplant, and then they'd have their transplant first, and they'd have probably a longer life expectancy because they were more well at the time of transplant. The third and final principle in which you could base an organ allocation scheme on would be benefit, the benefit of the transplant. And this is defined as people getting it would transplant people first who will get the most extra days of life because of their transplant. So the benefit principle is a mix of the first two goals, need and utility, and it aims to pick the patients first who are both likely to die without a transplant, yet also have a good enough life expectancy after their transplant. It's based on people's chances of being alive in 5 years with and without a transplant, and the way we measure benefit is the difference between the two, 5-year survival with transplant and 5-year survival without transplant. So at the moment, the National Liver Offering Scheme is based on the third goal, benefit from transplant, and it relies upon a computer algorithm to generate a national list of people, whereby people with the highest transplant benefit score come at the top of the list and are offered livers first. All of the three principles are important, but they can't all have an equal say or an equal weighting in an allocation system because each one would select a different person. So when one principle takes centre stage, it means another principle does less well. And Doug is going to talk us through how one principle impacts another if he's managed to join us yet.
He has managed to join us. There he is. Excellent. So as I mentioned earlier, we have got Professor Thorburn with us. But first, thank you very much to Laura for that. That was a very thorough covering of the current system. So thank you very much for that. I do want to remind everyone that we do have a question and answer feature. So you can click the little question box, should be in the middle below me or below whoever's talking. and you can type your question into there. We have Martine in the background who is collating the questions, so questions that are similar can be grouped together, and therefore we get through more questions. So please do that while people are talking, so we actually have some questions to ask. That would be amazing. In which case, if Doug, are you happy and ready to go? Me and Laura will turn off our videos and then we disappear from the screen, which is very clever. And Doug.
Okay, thanks very much. Thanks to Laura and also for Mark and for Martine in setting this up. So I'm Douglas Thorburn. I'm a liver physician at the Royal Free Hospital. I've got an interest in PSC. I've been the chair of LAG and finished in December of 2023. Since the autumn, I've been chairing the National Liver Offering Scheme Review Committee, and the aim is to try and finish the work and provide a report on the scheme to the medical director and senior management team of NHS Blood and Transplant by the summer. Hopefully before the summer holidays, but potentially after, hopefully before. So yeah, thanks for joining, and hope there's a chance here to encourage you to participate in the survey and explain a bit about what's going on, and then obviously answer questions as they come in. So Laura's given a very comprehensive, I think, overview of the scheme, and the first comment is these things are complex. It's complex because needing a liver transplant is a complex problem. And it's also complex because there's not the perfect solution. We live in an age where there's not enough donor livers, and there's too many people that need them. And so we've got to provide a scheme that will allow us to identify where the next donor liver is directed. And as Laura described, there are various sort of priorities or principles that sit behind the scheme that are for consideration. But I think it's important to remember what existed within the UK before NLOS was introduced in March of 2018. And prior to that, the donor organs were offered to each of the 6 liver transplant centres in England, and Edinburgh, the one transplant centre in Scotland. Those are the 7 transplant centres in the UK, and each centre got allocated a geography, and if a donor came up in that area, then the liver was provided to that centre, and then they would select who they would transplant from the waiting list. So the difficulty with that scheme is that each centre, if a patient was registered in one centre, they would have a different level of priority than they were registered in another centre, because there would be a different likelihood of a donor liver becoming available in that centre. And there also might be a different way that patients were prioritised within one centre versus another. Broadly, we were using one system, but there was no way to ensure that was what was happening. So effectively, the same patient with the same level of sickness in different parts of the country could be more or less likely to have a liver transplant. So the concern there was the scheme wasn't transparent, and it wasn't fair, and it wasn't equitable. So when the scheme was introduced, and it took 9 or 10 years in its development, one of the principles that was built into it was that it should be equitable, it should be fair, and fair to all. The desire was also to make it more transparent by using objective measures of people's need for a liver transplant. So all the things that Laura described are things that are clear cut. They're not based on the opinion of people. So the results of the blood tests, etc., are numbers that were done on a certain day. They're not open to interpretation. And it was using that kind of objective information on each patient in the waiting list would then result in a score that would allow people to be prioritized. And the other principles that were thought to be desirable when the scheme was introduced was to try and maximize the survival of the whole population of people that were needing a liver transplant. So that would be maximizing the survival of people before transplant, but after transplant too, over a period of 5 years. So the scheme sees people that are alive on the waiting list and people that are alive after a liver transplant the same, that because it counts that as a year of life. It doesn't matter to the scheme whether the person's had a transplant or not. If they're alive, then the scheme is delivering on what it's supposed to do. And the other principle that was built in was that it should try and minimize the number of deaths in the people that are waiting to have a liver transplant. And then in terms of the three choices that Laura was describing, so obviously needs-based system would, if that were to be chosen, then that's a system about always prioritizing the sickest patient. So if we've got a national waiting list, taking the patient that's sickest and transplanting them. The advantage of that scheme is that it would have an effect on the waiting list, deaths on the waiting list, because you're going to be prioritizing transplanting those patients that are at the greatest risk of dying. It's expected that with any patient on the waiting list who's active on the waiting list, that they're going to live for 5 years after their transplant. But ideally, we're expecting people to live for a lot longer than that, and they do. And if you use a needs-based system, what you're not putting any focus on is how long people are going to live after transplant. And we know that the sicker, once people get very sick, if you transplant them, the chance of them surviving is not as high as less sick patients that are being transplanted. So one of the downsides of this system is you might not be getting the best out of your donor organs because the donor organs that are a limited supply will not survive so long after transplantation with some of the other using some of the other methods of offering or priorities of offering. The alternative is the utility approach, which is you pick, when a donor organ becomes available, you select people that you anticipate are going to survive the longest after they have a transplant. And then you're making the best use of your donor organs, at least in terms of the years of life that people have with them after transplant. The downside of that approach is that you're not focusing on the patients who are sick and are at highest risk of dying, and therefore the people that are likely to live longest are likely to be the people that are less sick. You'll be bypassing the people that are sickest, who won't then get a transplant and will be at higher risk of death. So there's a risk of more deaths on the waiting list, and also transplanting patients that might actually have lived for quite a while without a transplant, but you just expect they're going to live a lot longer if they have a transplant. One of the difficulties with the utility scheme is that the way of determining what benefit or what utility is and predicting utility, it's difficult to measure that, and it's difficult to have a scheme that actually predicts long-term outcomes after transplant. So for the purposes of the current scheme, we've used the measure of utility as expected survival 5 years after they've had a transplant. One thing I didn't say about the need-based scheme is that that's the sort of scheme that most countries have that have got national schemes for liver offering. They prioritize the patients who are sickest, and there are a number of different scores that can predict survival of people with liver disease who are on the waiting list. There's not one score that's undoubtedly the best, but there are several that do it. and it's relatively easy to work out the likely survival and therefore to implement a needs-based system. The utility, as I say, is more complicated and it's harder to develop a score for that. And then the third thing, which is what we eventually settled on in 2018 after stakeholder engagement, etc., was a transplant benefit scheme, and that was trying to balance the two, balance need and utility by selecting patients that were deemed to be at high risk of death, but with predicted good outcome at 5 years after transplant if they were transplanted. And that's what the scheme has been established to do. Again, the difficulty with that is what's the, it's quite hard to describe. I think it is relatively transparent what it's setting out to do, but because the concepts are quite difficult, it's quite difficult for people to understand. So maybe it's not as transparent as it would be, as it would be desirable for the system to be. It has that problem also that because utility is built into it, then a score for utility and how we measure the utility within the scheme is difficult because we don't have scores that have been really well developed and validated to measure utility, although we've got one that exists within the scheme. So there's challenges really with each of the systems, and fundamentally the question is what's desirable in the scheme. As I mentioned to you at the start, the priority in the scheme was to maximize survival. So it's all about making sure people aren't dying on the list and maximizing survival of people that are transplanted after transplant. And the question that we are revisiting with this review is that still what's desirable with the scheme? And to that end, the questionnaire has been developed to ask some direct questions, but leave quite a lot of open questions to allow people to comment and express their views and opinions. And therefore, we'd very much welcome people's contribution to the review by responding to the survey. And I think with that, I'll probably stop and happy to take questions.
Excellent. I thank you very much for that, Doug. You can come back to Laura. There we go. Just don't want to be lonesome without you. Firstly, I'm going to apologize on Zoom's behalf. It appears Zoom doesn't like how long your title is, Doug. So I'm very sorry about that. You're Professor of Hepatology. So that was good. So we've got some questions coming in, which is great. Again, a reminder to anyone watching, you can use the question and answer function to send in questions. But I'm going to just start with a simple one that you started to touch on at the end there, Doug, which was what is possible to change? What is this review specifically looking at? Is it just the benefit need utility, or is it about anything transplant related?
So the National Liver Offering Scheme is the whole scheme. Within it, as Laura described, the transplant benefit score is used to determine who livers are offered to that come from DBD donors. But the National Liver Offering Scheme also encompasses the offering of DCD donors, and also people that are requiring multi-visceral transplants, so they are needing more than just a liver transplant alone. So all of it's really within scope, but the biggest change in 2018 was moving to a national liver offering scheme and using the transplant benefit system to prioritize the people that would be offered the livers. And exactly as Laura said, I didn't really emphasize this, but if we choose the scheme to do one thing, it's not going to do the other because we don't have enough resource to go around. So if we prioritize that we're going to do, need, then the consequences of that is that utility may there may be an impact on utility, but there will also be an impact on waiting times for the people with lower need as well.
That makes sense. Thank you. And slightly following on from that, we had a question from the audience saying they understand that views are being gathered, but who actually decides whether the system will change or not? Do you know that process? Has that been worked out?
So the review is, as I say, it began in autumn. There's the review's been commissioned by NHS Blood and Transplant, and the medical director is Derek Manis. I was appointed the chair, and then we put together a review committee with representatives of clinicians, patient groups, lay members, physicians, surgeons, doctors with an interest in young adult and pediatric transplantation. So we've got and we've tried to include all views. So we tried to make sure that we selected from across the kind of perspectives of transplantation, because we're wanting to kind of pull together. I think we all want the same thing, which is the best system that we can have within the resources that we've got. And at the end of and that committee of 17 people are to kind of come up with recommendations about what should happen to the scheme, and those recommendations then go back to Derek Manis and the senior management team at NHSBT to review and decide if they accept the report and then implement it.
And okay, we're following a series of questions here, which is quite good. But do you have a proposed timeline for that, for the sort of review to finish, the recommendations to be created, and then possibly even implemented?
So the review is, as I mentioned, due to finish this summer. We've already undertaken in January a stakeholder engagement event. These things take a little bit of time to arrange, so we were planning really from September, October when we started to have a stakeholder event, and that's how long it took to get it completed. And that was a professional stakeholders event. And at the same time that we started working on that, we agreed that we would undertake the survey, and we started working on that around October, November time. And we've engaged patients and families and donor families, particularly in the survey. And then we've had 3 focus groups as well for donor, a kind of donor families focus group, and then a couple of liver disease focus groups as well. So there's been a bit of a lead time with the process, but that's because we're really wanting to, we understand how people have strong opinions on the topic, and there's a desire, there's obvious concerns about the scheme as it exists at the moment. And that's why we're really keen to consult with people and get views. But I think the key message is that internationally, if there was one system that worked better than everything, everyone would be using it. The second thing is it's complex, and the third thing is I think we have to kind of determine and agree what we think the underlying principles are. I mean, one of the things that we haven't spoken about here is, before the Americans introduced a needs-based system, their system was based on waiting time, or had a large waiting time element in it. But the problem is that if you just put people on the list because the longer you wait, the more likely you are to get a transplant, that the behavior that creates is people list patients for transplant earlier and earlier, and it just becomes a queue. And there's no way within that queue that you can identify who are the people that really need it. So that's why it's so important that we've got to, we haven't gone for that as an option. And what we're looking at, we didn't go for that in 2018, and we still don't think that sort of system is a good idea. It's not. We need to use the resource we have best for the population that need a liver transplant. But we need to know what professionals and patients think are the group of patients whose need is the greatest.
Thank you. That makes sense. And you mentioned in there the potential for groups of people to be potentially disadvantaged by a certain choice in the system or a certain focus. It has been mentioned before, and you've helped us with this before, but is there any chance that PSC people are being disadvantaged? I know it's come up before, and we've had discussions around this.
So within the scheme, again, it's really key to think what was the scheme set up out to do. And the scheme was set out to maximize survival by ensuring the patients that would benefit most from transplant would be prioritized and would, get offered livers and get transplanted first. I think it's really important to remember that when the scheme was introduced, about 70% of the donors that were available within the scheme were DBD donors, but there's been about a 30% reduction in the number of DBD donors that there are now compared to when the scheme was introduced. So in reality, everybody is disadvantaged now compared to what it was like in the scheme was introduced, because there's fewer donors to offer within the scheme. And nowadays, about 50% of the donors that we've got are from DCD donors, and they are available for the centre to, choose who they're going to allocate those livers to. So the scheme was designed to balance need and utility with this transplant benefit. And I suppose, to get to the point of your question, one of the concerns that's been expressed is around the prioritization of older patients within the scheme. And that was anticipated to be the case in advance of it being launched. So it didn't come as a surprise. That was known and recognized that that was going to happen. And the reason for that happening is because age is within the calculation of need within the scheme. And we know that older patients, if everything is the same, the disease is the same, the liver disease severity is the same, etc., older patients survive less long because of often they're a bit more frail, they've maybe got more comorbidities, etc. And therefore, age is a predictor of risk of dying on the waiting list. So because the scheme was developed to maximize survival, minimize waiting list mortality, it therefore prioritized patients who were older, who were at higher risk of dying. And that was, as I say, was something that was kind of known that the scheme was going to deliver. But the consequence of that is that other groups of patients are waiting longer for their transplant. And we know younger patients and patients with certain diseases, and PSC would be an example of that, are able to wait longer. I'm not in any way suggesting they deserve to wait longer. I just mean that because they have got more physiological reserve, and because with PSC, people don't deteriorate in quite the same way as people with liver disease from other causes with the same severity of liver disease. There has been an effect which has meant that those groups of patients have waited longer. And again, that was anticipated with the scheme on introduction of the scheme. But that was because the choice was made to try and maximize the survival. And as I tried to say when I was, doing my talk, that the scheme doesn't differentiate between people who are alive on the waiting list and alive after transplant. They both count as sort of successes within the scheme, the way it's constructed. And that accounts for why, why the things have happened that people have observed. I guess this is the chance to revisit that and say, is that the principle that we want? And is that what we're setting out to achieve within the scheme?
So linked to that, the way in which need is calculated, and I'm not saying that need as in the whole need system, but need as a part of the benefit score. That's calculated by a sort of purely medical point of view. It's blood tests and figures. It's not quality of life measurements or anything like that. And is that something that could potentially change?
So that's something that comes up regularly. It is based on objective measures. There's about 17 recipient things that are put into the measure of need within the system. The difficulty, and I've, as you know, involved in developing quality of life tools in PSC, and we've developed a patient-reported experience measure in liver disease as well. But there's no validated tools that are, validated in the transplant setting as accurate measures of quality of life. And the problem is, unless you've got those tools, it's not possible to apply them to this sort of scenario. The other issue is that we don't have data on quality of life. So the scheme has been developed by using retrospective data on people that have been on the waiting list to develop scores and then test scores. And because we don't have data on quality of life in any detail, and we don't really know what would be a good measure to measure, we can't factor that into the scheme. So the scheme is very much about, survival. That's the measure of success within the scheme. And I would absolutely agree with you. That's, that isn't what patients would see as being important, or they would see that as important, but it might not be the most important thing. It might be the quality of life, and people on waiting on the list and their quality of life, their experience of waiting, is likely very different from many of the patients who in the first year after transplant, but we just don't have the tools to measure that in a way that would be robust to build into an allocation scheme.
But I guess this survey is a good way to gather if that is an important factor to patients. Even if there's nothing we can do right now, it would be good to have that information. We've spoken about scoring things. How do you score utility and benefit? Is that an objective measure or is that a subjective measure?
So as I say, within the scheme, so this scheme is the only scheme internationally that has got utility built into it. And there is some logic in saying, well, let's not just, pick the sickest, but let's pick people that we think are going to do well, and if we can calculate the way that the utility side has been calculated at the moment is the prediction of survival 5 years after transplant. The reality, however, is that because the people on the waiting list are a super selected bunch of people, and they're physiologically fit, the actual difference from one individual to the next in terms of the likelihood of them being alive at 5 years after the transplant is quite small. The majority of the emphasis of the score is around the risk of death while waiting for transplant. So most of the emphasis, although it's a transplant benefit score, most of the emphasis of the score is around the differences in the likelihood of dying within the, at 5 years if you don't have a transplant.
And we got a question sort of linked to that, which is why is the life expectancy limited to 5 years? Is that just we don't have the data for longer, or that the balance of including a longer time frame there may have consequences somewhere else? Could you speak to that maybe?
Yeah. So at the time it was selected because after transplant, the longer out you go from transplant, the more likely people are to die from some other cause. It may be related to transplant. So infection, cancer, and renal disease are, the main sorts of infection, cardiovascular disease, renal disease, and cancer are probably the main things. But it was felt that it became harder to predict the longer term outcomes. There is data within the National Transplant Registry that for every patient really that's been transplanted in the country, including each of the centres has to give annual data on survival and etc. on their patients. But as I say, there haven't been that many. Well, you know, what's the best measure of utility? I don't think has generally been agreed, and as a consequence, we don't have a tool for measuring it, and we don't know how accurate we are in measuring.
Are there, this is a question that's come in, it's quite interesting. Are there examples of other countries that just use solely utility, or maybe a longer period to do that, to do the offering?
No, there's not. There aren't countries that use utility alone. And I think that's largely for the reason that you could be, you know, you'll be taking patients who are, you'll be bypassing the sick patients, and they can't afford to wait. And generally people think that's transplant saves life. So it seems illogical that you would be bypassing those. That's how you get onto the transplant waiting list, is the chance of being dead in a year's time without a transplant is higher than the risk of you dying if you were you to have a transplant at that point. And then that's generally the point where people start looking at considering registering people for transplant. So utility alone is not a scheme that's been implemented anywhere.
That makes sense. Thank you. And I suppose this question links in with that a little bit as well, which is if we were to prioritize liver transplants by projected healthy years, so that would be the utility, I guess, does that have the risk of unnecessary early transplants, if there is such a thing for people who are on the list?
So if you know, everybody that goes onto the list is on the list because the centre that's looking after them believes that they would be better off with a transplant than without a transplant. So the first thing is that nobody on the list should be somebody that doesn't need a transplant. But it's true, with a utility approach, you might transplant patients whose life expectancy would be long without a transplant. So actually, you know, if you did nothing, their life expectancy might be reasonably good without a liver transplant, but might be even better with a liver transplant. But that's but they wouldn't be people that didn't need a liver transplant, because they wouldn't be on the list if they didn't need a liver transplant.
That makes sense. A question again from the people watching. So thank you for sending questions in. It's really good. Is the consensus from the powers that be, the doctors and the researchers, that the system needs to be changed? Is that what's kicked off this review, or is this just a sort of a standard 5-year review?
So it's standard on the implementation of these of the offering schemes at NHSBT that reviews that take place. So there's been a prior renal review, and they've reviewed it in cardiothoracics as well. And this was kind of commissioned after we reached a 5-year point. But you know, it's the reason that we're engaging in the way that, so it was always going to take place, but there's a lot of strong feelings about the scheme as it exists at the moment, and that's why we felt it was really important to kind of understand what those concerns and thoughts were and what people think is desirable within the scheme.
And I think it's come across that you're very interested in looking at the base underlying principle of the system. This survival, be that pre or post transplant, is fundamental, which is what leads into the talk around utility, benefit, and need. almost forgot that one. But there are other factors of the National Liver Offering Scheme, like the regional, national slight split between brain death donors and cardiac death donors. And you are, just to reiterate, you are gathering information or people's thoughts about all those aspects as well then, or is this focused purely on that more fundamental side of it?
No, as I said, the National Liver Offering Scheme is the whole thing. So the review is of the whole thing. And up until the 11th hour of the implementation of the scheme, the plan had been for DCD donors to be inside NLOS when it was launched. It was a slightly different era then, because machine perfusion and techniques like normothermic regional perfusion, which are again technical approaches to trying to improve the quality of a DCD donor, or test the viability, test how good the liver is, weren't available. And at that time, there was a lot of anxiety about flying, about organs traveling up and down the country that were more fragile, let's say the DCD organs. So that's why it was left out. At that time, the DCDs were only about 30% of the scheme. These days, DCD organs are about 50% of the scheme. I think it's a really crucial element of this to consider the role of DCD organs within the scheme. Absolutely.
I think as well, just to add to that, Doug, there's some free text questions within the survey. One of them, for example, being, is there anything else you think should be an important part of deciding who should get a liver transplant first? As well as some other free text questions about what do you think is good about the current scheme and what's not so good. So the opportunity for sort of adding in other issues regardless of the three principles as well in those questions.
Thank you. It's good that those views are being gathered, so that's really useful. Thank you. I know we're coming up to the end of our time. There's a few more questions. If we maybe try and do these as quick fire, but I understand this is a subject that might not necessarily lend itself to that. But we've had a question of how is the sickest patient calculated? Is it just blood test results done on a day, or the UCALD score maybe? And would those very specific measures, would they actually reflect the truest sickest person, or the extent of, say, the liver damage that they've got?
So in the transplant benefit score, there's a score. The need element of the score is called the M1 score, and there's various parameters that are within that. In the US, they've had various versions of the MELD score as a means of prioritizing their patients. And then there's another more recent score that was developed by one of my colleagues actually here at the Royal Free called the GEMMA sodium score. And that's been used in Australia, and they're looking at implementing it in Europe. And each of them uses different parameters, but they're a measure of how, predominantly they're based on the function of the liver and how severe the person's liver disease is. Obviously, the people on the waiting list, it's more complex because some of them have heart disease, some of them have lung disease, some of them have diabetes, other conditions, etc. These factors aren't really taken into account in the offering schemes because, again, the people in the waiting list are a super select group of patients that have been deemed to be fit enough, etc.
Thank you. We've got a question here. How many people die within a year of being transplanted? Do you have a statistic like that? I guess that's the sort of the 1 year survival rate.
So these days it's around 90, high 95, so almost 96%.
That's survival rate, not dying rate.
No, survival rate. So
yeah.
It's around 5% 1 year survival, and it's around 80%. 1 year, and it's around 80% 5 year survival. And it's important to remember the sort of average age of people that are undergoing a liver transplant in the UK are about 55. That's the average age people. So, you know, the outcomes are really very favourable. It has to be said.
I didn't know that little tidbit of information that it's 55 is the average age. In fact, that takes us to a kind of a common question we often get as a patient organisation: is there an age limit for transplant? And I know we touched earlier on age and how that links in with the benefit score, but is there a sort of an upper point at which point you don't get any livers?
Not as such. There's no age cutoff, because the key thing is that the people that we put on the list, we believe would benefit from a transplant and would be more than likely to be alive 5 years after they're transplanted. Now, if you've got 100 people that are 30, the vast majority of them are going to be suitable. If you've got 100 people that are 60, a good, still a very high number of them would be. If you've got 100 people that are 70, the numbers of people that would be suitable for a liver transplant are getting quite a lot smaller. But there's not a cutoff, which means when you hit that age, you can't have a transplant.
That's good to know. Thank you. So we're coming to the end. We've only got a few minutes left. I did want to say that one of our viewers is saying to give some encouragement to those who are on the waiting list or might be heading that way. They had their transplant in 2003 when they were assessed to only have a few months to live. And that's given them another 21 years so far. So, there are good outcomes out there for liver transplant. I'm hoping for something similar. I had my transplant almost 2 years ago now, and I'm hoping to get at least an extra 0 on the end of that. And so that's good.
It's an important point that PSC is amongst the best indications for liver transplant. Fair enough, it can recur, but still, the life expectancy of people after a liver transplant for PSC is amongst the highest.
That's good. That's a bit of good news. That's good. So as a group, as PSC support, what are the sort of key takeaways from this? Why is it important for people to do the survey? What should we be telling our patients and their networks? Why fill it in? What's the drive for this?
I'll say, and then maybe Laura can say as well. But genuinely, we want to gather opinions about the scheme. The scheme, you can see that the scheme can do a range of things, and the question is, well, what is the thing that we want it to do? And we need people's opinions on that to support us in knowing what we would be recommending. So it's really crucial we get that feedback. That would be my starter for 10. Laura?
Yeah, I would say, I think in this era, the era we're in now, the NHS has never been more pro gaining the patient public perspective in initiatives and things and plans moving forward. So it's almost now become a real integral part of change and moving forward with a change. I asked Doug this question for the last focus group as to what extent was the patient public voice gathered for 2018 when NLOS was introduced, and it was absolutely nothing on the scale we're trying to engage with people now. So it's a real opportunity to shape the future of national liver offering, and so absolutely please use your voice and have your say through the survey.
Thank you. And will the results of the survey be published? And if so, where would people in however many months be able to see that?
So, Laura, you may want to comment.
I was going to say, probably not so much in the sense of the data extracted from the survey, although it is all anonymous. It won't probably be published as survey data, but it will certainly form part of the overall report and recommendations in which come out of this. Would you agree, Dave?
Yeah, I suspect that some form of the survey will be included in the report when it's, some kind of analysis and summary of the survey will be included in the report. We haven't, at the moment, we've been very focused on just getting the information. but I absolutely agree. It will be important to ensure that the people that have given of their time to provide the information are kept informed about the review and the information that we're gathering and what we're doing with it. But so the aim is throughout the whole process from start to finish to be as transparent as we can be. So all I can say is we give a commitment to that.
Brilliant, thank you. The final two questions. I know we're over by a minute, but it's if PSC patients, as you said, Doug, do very well survival post-transplant, we tend to be one of the groups that do better. Would that mean it could be in our interest to push for a utility-based system?
As I say, I think the difficulty with utility on its own is that it's, you know, what would the measure be? And if you look at 5 years, the difference between PSC and other groups is really small. The difference in outcome at 5 years between younger and older patients is really quite small. So I think a utility alone system has quite a lot of challenge to it. And I suppose some of those aspects are carried into the transplant benefit system as well, because, you know, if you're going to put utility at all into the score, then, you know, it can complicate matters, let's put it that way. But there is something that's attractive about the idea of selecting people that are going to have a good outcome and make the best use of the liver, sort of thing. But that's, as we've described, you know, there's many ways of measuring that: survival, quality of life, and we can only really measure survival within the scheme.
But I suppose as the benefit scheme is a mixture of both need and utility in different proportions, it might be possible to tweak the algorithm to make that more of a focus. So yeah. And finally, the final question, because I think it's important in all walks of life, but maybe from each of you individually, what can we all do to try and get more livers to be available? How can we best promote organ donation?
That's a really good question. There's a review going to be taking place on all aspects of donation to try and understand why we've seen a fall in donation. I think a key thing is it doesn't seem to relate to opt-out legislation, etc. There is an element that's associated with brainstem death testing in intensive care units, and there is an element about the rate of consent that people are, when people are approached, their willingness to consent to, you know, donation of their loved one, etc. I think what we need to do is, and you know, people with loved ones and people with is to kind of tell the story of the benefits of transplantation, and the life-changing thing that transplantation can be for patients and for their families, to demonstrate or to, and I guess everyone's got a voice with that, and it's about being positive about the benefits, I suppose. Laura, you may wish to comment further.
Yeah, my view would be to start the conversation with family, friends about organ donation. The legislation, since its launch, the opt-in, the deemed consent legislation, since its launch in 2020 has not quite gone the way we anticipated it to. There's some elements of confusion about what people need to do. Do we register our expression to donate? Do we not need to do anything at all? But I would absolutely encourage, there is still an organ donation register for people to express their wishes via that system, because in the time of death, if that conversation has not happened between a potential donor and their loved ones, that family are able to override the decision of a person who may have felt in their heart they would want to donate their organs, but actually never got round to having that conversation or registering their intention to donate. So absolutely spread the word. There still is an organ donation register. Sign up to that, but also have the conversation with your loved ones and encourage them to have further conversations with their loved ones, colleagues, friends about their wishes. And I think the momentum can build.
That's brilliant. Thank you very much. I wholeheartedly agree with what both of you said, and we will definitely keep an eye open for the organ donation review as well. That will be absolutely brilliant, and hopefully we'll bring some more information about that. So I'm just going to wrap up. I just want to say thank you very much to you, Laura, and to you, Professor Thorburn, for your time. You've given it for free today, and we really do appreciate it. We have a page on our website which links to the survey. It gives some information around it, and this video will be embedded in that website, hopefully tomorrow once we get it. The link is in the chat, so you please go there and you can then go through to do the survey. Yes, that's it. We got another webinar actually a week today by the wonderful Jess Dyson about PSC past, present and future, and we have an in-person information day coming up. That's going to be on Saturday the 3rd of May in the Celtic Manor Resort in Wales. Please come along. It's an amazing venue. It's going to be a great day. You can find information about both of those on our website, which is pscsupport.org.uk. Thank you all for all of your amazing questions. Thank you again to Professor Thorburn. Thank you to Laura. Thank you to Martine for being amazing and support in the background. You have no idea how much work she's been doing off screen. It's been incredibly useful. So thank you to everyone. I'm going to end this now, and Zoom quite rudely just kicks everyone out. So I will say goodbye. Thank you very much, everyone.
Bye.
Bye. Thank you.